Again today with Dr. Irene Ghobrial from Dana-Farber Cancer Institute and Dr. Karen Winkfield from the Meharry Vanderbilt Alliance about multiple myeloma. Now, is this a lethal disease?
So Virgil, that's a very important question. We know we've made amazing progress in curing cancers. Again, some of the cancers, breast cancer, prostate cancer, if found early enough, we can cure. Multiple myeloma, we're not quite there yet. However, there have been some very significant changes that have been made, innovations in therapeutics that have really lengthened the lifespan of individuals with multiple myeloma. Not only in terms of treatment and different types of directed therapies, but even thinking about using things like stem cell transplant. So it's the combination of therapies that actually can help ensure that people who have a multiple myeloma diagnosis can live much longer.
Well, you talked, a little bit earlier about the fact that the incidence to mortality ratio is higher than breast cancer and prostate cancer. Again, we started looking at it. What's the comparable incidence and mortality of multiple myeloma from the general population against, say, the high-risk population of people of African descent, Latinos, etc.? Dr. Ghobrial?
Well, I would say that, and that's actually unfortunate, right? That if you look at the survival of patients with multiple myeloma and see who are the patients who are actually getting that longer survival, unfortunately, it's not for the African Americans. Unfortunately, survival in African Americans with myeloma is still very poor. And that's a shame on us because we need to do better. We can do a big difference here. Diagnose correctly, treat correctly, access to care, access to clinical trials. There are so many things that we can do. So we know that the risk of myeloma is much higher in an African American, yet their survival is worse, not because they have worse features, not because they have worse cytogenetics or worse biology. It's truly because a big part of it is because of our care, although we still don't understand all of the underlying biology. We don't understand all of the underlying changes in a cancer cell, and is it different? And can we specifically say, let's do something correct, let's do precision medicine for everyone and not just use trials and drugs that were developed in 98% white and then apply it to everyone else.
Yeah, and it's really important.
I'm sorry, go ahead, Dr. Winkfield.
Yeah, no, I just wanted to mention that. So when you talk about the difference in terms of incidence, when you think about that precursor lesion, MGUS, right, the monoclonal gammopathy, it actually is more prevalent, about 2 to 3 times more prevalent in Blacks, okay? And even Hispanics actually have a pretty high risk of MGUS, and they tend to also get MGUS and develop MGUS earlier. Doesn't always lead to the development of multiple myeloma, but this is a huge disparity. People often talk about prostate cancer in Black men and how they have a 1.5 times higher risk of developing prostate cancer and a 2 times higher risk of dying of prostate cancer. As Dr. Ghobrial just mentioned, so we have a 2 to 3 times higher risk in Blacks of developing multiple myeloma and a 2 times higher risk of dying of it. Okay, that's problematic. And if you look at the trials that have been done, the studies where they did include Blacks actually did better when they actually received the appropriate treatment. So this is not a matter of a biology necessarily being different or predisposing them to worse outcomes. This is simply a matter of access to care and appropriate care.
I think it's something, we look at, Ike Powell and Carmanos in Detroit, who did the study of prostate cancer. And he said basically that if you give people equal access to care and you treat them at the same stage, the outcomes are no different. So I think it's good. But again, getting back to the point, we are seeing now the necessity of doing genetic screening to be able to see how certain populations will respond to certain treatments in terms of getting to precision medicine. Do we know, with terms of multiple myeloma, is there any genetic differences or chromosomal changes in different populations that would predispose them for it more than others?
Yeah, I mean, this is a question that has multiple layers. So there is a question of predisposition. Are we at risk? And indeed, just like Dr. Winkfield said, Blacks are at a much higher, 2 to 3 times higher chance of developing MGUS, myeloma in general. We don't know why. So is that a germline that we need to do, which is germline sequencing? Can we understand why? It could be an immune level. It could be an epigenetic level. So these are the questions that we are asking now. When we take that research sample, we are asking those questions. Why is someone at risk? And can we understand it better so that we can screen the population at the genetic level, not by race and age and factors that are not truly precise. So the hope is we take it from race into genetics and from age into actual epigenetics and understanding it better. The second question is, molecularly, when the cancer cells develop, are they slightly different in biology? Are they the ones who are more aggressive or less aggressive? And although we don't have all of the data, there is controversy. There are some studies that say, actually, African Americans get 11-14, which is one of the better or standard prognostic features of myeloma. It's not the ones that are bad. Let's actually understand this better and let's understand the biology better. But because we don't have that much data, we don't have all of the knowledge to make major decisions in our treatment.
And can I just say, remember, race is a social construct. It's not genetic.
Absolutely.
And so certainly looking at ancestral DNA and looking at where, people may have come from may provide insights. But I actually think one of the things that I'm really excited about is looking at epigenetic changes, those changes that happen based on people's lived experience.
Right.
And so it's not just about looking at DNA, but you have to understand the social context of people. What are their social
factors? Yes.
Exactly, right? Where do people live? What are the stresses they're under? Because those are the things that can imprint on the DNA and cause it to be transcribed or expressed in one way or another. And to me, that's more important when we look at what's happened to Blacks in the United States because of the pressures and the external stressors that are on their bodies on an everyday basis.
And we know that stress is an accelerant to all kinds of cancers and all kinds of other diseases. And if there's been a population under stress, it has been people of African descent. So no question about it. But just for skew for just a moment, forgetting about the issue of so-called race and gender, women versus men, are there any different risk factors there?
Yeah, so I'm gonna, yes, so men actually have a higher predisposition to the development of multiple myeloma. Again, I'm not 100% sure why. Maybe Dr. Ghobrial has some insights into why men have that higher predisposition. Maybe it's stress for them too, I don't know. But we do know that men, about 2 to 1 actually, have a higher predisposition for the development of multiple myeloma.
Okay.
Yeah, it is very interesting. And we are actually starting to see, is there something in the X and Y chromosomes and does it predispose to certain cancers? It has been shown actually in other cancers that maybe that predisposition of male to female is related to that. But I'll have to tell you that in the PROMISE study, we actually found more women are willing to be screened than men. So we actually have the reverse in the screening, and probably because women are much more comfortable with screening studies in general, mammography, pap smears. But we do want to encourage men. They're the ones who are at risk more. So if anything, if it's one message, is encouraging men to start thinking of it earlier.
Well, again, women are, I think, more predisposed toward interacting with the healthcare system than men are. We've done a lot of, outreach programs. And again, if a guy, doesn't have 2 broken limbs and bleeding from 5 orifices, he's not going to the doctor. So that's something different. But now,
Indeed.
Getting back to that, again, we talked about, in other episodes, the PROMISE study. Now, how do you think that the PROMISE study is going to help minimize the risk from multiple myeloma?
Yeah, I mean, I think what Dr. Winkfield just said earlier, we treat myeloma and we have made a huge difference in survival and we have better therapy, but we're still treating way too late. So think of it, if I diagnose you today with an early lung cancer or early colon cancer, and I tell you, but you're asymptomatic, you're doing fine. Why don't you go live your life, be fine until you have metastasis everywhere, fractures in your bones, kidney failure, and then I'll treat you because you're not symptomatic yet. You will think I'm crazy. Right. Now, I do that every single day with multiple myeloma, and people don't think that that's crazy. We wait for people to have something called CRAB criteria, fractures in their bones, anemia, renal failure, and high calcium. That's the diagnosis of myeloma, and that's completely wrong. And it came from the good old days when we had nothing to treat myeloma. So we said, let's wait for them until they have symptoms and treat them. That's fine when it was, 1800s. It's not fine these days anymore, and we should change that. So only by diagnosing people early when they are asymptomatic, then we can treat them early before they develop end organ damage. Then we can potentially say we're as good as all those other cancers who treat people appropriately at the right time. There is nothing precursory in smoldering myeloma. The cancer cells are the same. They just did not kill, your kidney or caused anemia. There's nothing good about those cancer cells.
Yeah. And I think the beautiful thing about the PROMISE study is, again, thinking about, is there a way to prevent, multiple myeloma? Can we actually stop the progression of the disease? But part of it, you have to understand what the progression of the disease is. We're still learning. And I think that's the beauty of this study, is it will follow people longitudinally over years to really try to ascertain what some of the things are that we need to be thinking about when it comes to molecular biology, but also the development or the movement from MGUS into multiple myeloma.
Well, it's excellent information from both of you. We're going to talk more with you in the future on this subject. Thanks again.
Thank you.
Thank you.